Acute compartment syndrome is a medical emergency. Therefore, if it's not treated and recognized immediately, it can result in the loss of a limb. This is a condition in which increased compartment pressure passes a critical level, resulting in compromised neurological function and tissue ischemia within the space. Compartment syndrome can occur anywhere in the body where there is a fascial envelope that is non-compliant and unyielding, which in turn increases the intracompartmental pressure. This issue is going to occur primarily in the lower leg, but can also be seen in the forearm. It is found in the gluteal muscles and, interestingly enough, in the ocular region. The mechanism of injury for an acute compartment syndrome can stem from two different areas. First, you may have a decreased compartment size. This can be due to the localized external pressure or the excessive traction to a fractured limb. The second is an increased compartment content, and this can be due to increased capillary permeability and increased capillary pressure simply due to bleeding. So if you think about the compartments and how it's surrounded with that fascia, any excess of tissue, in this case blood, can put too much pressure on that compartment itself because it does not give like a muscle, for example, would. There are 7 P's of clinical symptoms before the onset of ischemic dysfunction in nerves and muscle due to compartment syndrome. These are important to keep in mind because collectively these can point directly to an acute compartment syndrome. Those 7 P's include pain, aggravation of pain by passive stretching, intracompartmental pressure. The person's pulses may be absent, so we're looking for the pulse distal to the compartmental pressure. There may be paresthesia, pallor, or paresis. Signs and symptoms can include edema along the length of the involved compartment, a general glossy appearance to the skin, pallor, which is paleness, severe pain that is deep and progressive and disproportionate to the injury itself, and the person will become dysfunctional. Range of motion wise, we are going to see a decreased active and passive range of motion of the involved compartment muscles. So for an anterior compartment, that would be dorsiflexion. For a posterior compartment, it would be plantar flexion. For the lateral compartment, you would see that decrease in eversion, although the inversion you may notice pain due to the stretch. There is not any special test per se, but what we would do is create an eccentric stretch of that compartment. So for anterior, we're going to do an eccentric test for plantar flexion. Neurovascularly, we really have to pay close attention to both the motor as well as the sensory components. Paresthesia in the involved compartment dermatome area can be very indicative of a compartment syndrome. We will see that the increased pressure decreases the nerve's ability to propagate an action potential, causing that numbness. The arterial pressure is also going to be greater in the elevated tissue pressure in a compartment syndrome, which is going to lead to paresis. Diagnosis is going to be done with a transducer, and if you have never seen one of these, think to how you might test tire pressure. Same idea. You have a needle that goes into the compartment and it literally measures the amount of pressure that you have in that compartment. When treating acute compartment syndrome, we need to remember that this is a true medical emergency. We initially will do a triage of the injury. Because we already have a lot of compression, we definitely don't want to add more. So ice, no compression elevation may be beneficial. However, the injured extremity should not be elevated above heart level. We want it placed at heart level to optimize the arterial pressure and venous drainage. We're going to try conservative treatment at first, but if that doesn't work, we will move on to the fasciotomy, as you can see in this picture.